Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Inside the Issue. As today we talk about the management of non-melanoma skin cancers, specifically basal cell cancer and squamous cell cancer of the skin. We have a great faculty today, Dr. Nikhil Khushalani from the Department of Cutaneous Oncology at the Moffitt Cancer Center in Tampa, and Dr. Anna Pavlick from the Weill Cornell Medicine Meyer Cancer Center in New York City. We have some other investigators who are nice enough to complete a survey, and we'll show you the results of that survey later on in the program. As with all of our webinars, if you have any questions or cases you'd like to run by us, just type them into the chat room. We'll talk about as many of these as we have time. Also, we put a short 1-minute pre-meeting survey and post-meeting survey in the chat room for you to take. If you take that, we'll learn a little bit about you, and you'll get a lot more out of this meeting. So the next 2 Saturdays, we're going to be on the road. We'd love to have you join us. This coming Saturday, we'll be in Orlando. If you're there, drop on in. Or if not, check it out online. We'll be with the Florida cancer specialists talking about a variety of cancers. And then a week from Saturday, we'll be out in Las Vegas with the American Oncology Network, and we'll deal with a whole bunch of other cancers. So between these 2 Saturdays, there'll be a real update on what's going on in oncology, but there's so much more. And to try to deal with that, we're actually going to spend an entire weekend next March in Miami, our hometown, for our third annual summit that we've been doing on general medical oncology. We'll be talking about 25 different tumor types, a ton of investigators. I hope you can join us here or join us online next March. We know a lot of people end up listening to our programs. If you're into podcasts, check out our Oncology Today series, including a recent program with Professor Long on melanoma. But today we're here to talk about non-melanoma, particularly squamous cell and basal cell particularly. And as we do with all these Inside the Issue programs, I met with each faculty member in the last week, and just a reminder that in all of our programs we do discuss off-label indication use of agents, so keep that in mind. We're really here to try to attack the issue of the risks and benefits of various therapies. But as we do in all these programs, I met with the faculty actually last week. We recorded their in-depth presentations covering these 2 topics. And in this webinar, we're going to try to take it to the next level, but they're in the chat room. We'll send out in an email also when we send this webinar these 2 presentations. If you do all 3 things, you'll learn a lot more. Our faculty covered a lot of papers, a lot of issues, and presented some great cases. If we have time, we'll show you some of the interesting photos from these cases, as we often see. But really you should check out the presentation for some real in-depth discussion. Here's where we're heading today. We're going to have a little intro and talk about a little bit about where things are today with this, and then we'll talk about squamous cell, basal cell, and then some of the ongoing trials. So Nikhil, when I say why did it take so long, my question is, why did it take so long for checkpoint inhibitors to enter this field? We'll get to that in a second, but while you're answering, I'd like the audience to answer the question also. We're going to, as a poll, how many patients with either basal cell or squamous cell do you have in your practice? Do you have any patients? If you could, just type in, and I'm curious how many patients are in the practices of our faculty, of our attendees. But Nikhil, when you think about these cancers, sunlight-related cancers, nowadays, the first thing we would start thinking about, we'll talk a little bit later about TMB, et cetera, would be IOs, but yet it seemed to take a while to sort of get there. We had long already, so many agents approved, melanoma, of course. Any thoughts? Part of the issue, I wonder, is really keeping track of these cancers. There's so many, the denominator is so huge that trying to figure out where those small number of patients are who really need systemic therapy. Any thoughts about this question? Actually, it looks like almost all of our audience has some patients in their practice. And actually, a fair number, actually almost 20% have more than 5 patients. So it looks like, I don't know if they're typical for oncologists. But Nikhil, as you're answering that question, I'm going to ask this question also to the audience, which is, how many times have you seen a patient with basal cell or squamous have a great response to anti-PD-1, and they don't need treatment for at least 3 years. So while we're waiting for their answers, Nikhil, any thoughts about sort of why it took so long, particularly for IOs, to get into this space?
Well, I think that's a great question, and you point out the obvious. Number one is the denominator is so large. These are tumors that primarily are within the domain of the dermatologist. It's only about 3 to 5% of them that eventually, at least for cutaneous squamous cell, go on to developing nodal metastatic disease or locally advanced unresectable tumors post-surgery and or radiotherapy, and then eventually find their way to the medical oncologist. Now, traditionally, CSCC has been treated along the pathway of other squamous cells with chemotherapy, paclitaxel-based regimens or platinum-based regimens or 5-fluorouracil, and that for a long time, even recently, was still the standard of care. I think it was only almost a serendipitous finding and trying to understand the molecular biology that immune checkpoint inhibitors have really come into their own, particularly with CSCC. And quite frankly, I mean, these are not what I would call, quote unquote, the sexy diseases where, you expect to see a lot of these patients and make an immediate impact. And so I think that's one of the reasons why they haven't come to the forefront until only recently.
And it's interesting, more than half, almost 2/3 of our audience has had at least one patient with a 3-year response. So I think people are starting to see how responsive. And I love this slide that was in Nikhil's talk, looking at TMB in response to therapy in different cancers. And I just wanted to point out over there on the right where you see the higher TMB levels. So if you see colorectal on the very right there, with TMB in the range of 50, and you can see the response rates, 30%. But then you look straight up where the arrow is, and you have cutaneous squamous cell, and actually around where basal cell is also even higher than MSI high in terms of response, and similar TMB like around 50. Anna, oncologists, nowadays we have our eyes open for TMB that's over 10. To see a patient who's got a TMB of 50 is pretty impressive, and so are the photographs you all show in your cases. I mean, amazing responses. Any thoughts about about this, the background here? And also, there's a little, kind of a discrepancy. Both squamous cell and basal have very high TMB, but yeah, you see much better responses to IOs with squamous cells. So there's more going on. But any thoughts in general about sort of immune responsiveness in general of these two cancers, Anna?
Yeah, I mean, we know that these tumors have very high expression, which is part of the reason why we don't routinely check PD-L1 status on our squames. We don't check for mutations on our basals. But uniformly, squamous cells have very rapid responses to PD-1 inhibitors. In fact, I routinely tell people that if you've had several cycles of PD-1 and you've got a tumor that looks like it's getting bigger, please don't be fooled and think that this is pseudo-progression, that this is clear-cut progression of disease and you need to switch gears and do something differently because they do respond so quickly. Basal cells, on the other hand, are much slower. They will respond, but you got to give them time before you actually see some type of response.
So I want to try to spend as much time as possible on the clinical survey because it really gets into the nitty-gritty of taking care of these patients. And obviously, there are not that many in the practice of a typical medical oncologist. But one other thing I wanted to just get your thoughts on, Nikhil. This is a slide you showed. And of course, with squamous cell, and we're going to start to move now into cutaneous squamous cell, we see this in immune suppressed patients, solid transplant, status post-transplant, CLL, HIV, allo transplant. Can you talk a little bit about this phenomenon, Nikhil, and how it affects specialized center? Anna, Anna's question on how many people you've seen with more than 3-year responses was tons. We should have put that as a possible answer, although I'm not sure the audience would have answered that. But maybe if we could just kind of get into a little bit into the issue of immune suppression and how many of these patients sort of fall into that category. And of course, there you have the issue of IOs. But Nikhil, can you kind of provide an overview of the issue?
Happy to do so. So as I've pointed out in this slide, patients who are solid organ transplant recipients have a dramatically higher incidence of developing cutaneous squamous cell cancer. In fact, that's the most common cancer that these patients land up developing. And what you see here is essentially a study that looked at renal transplants and over two separate time periods, over 10,000 patients, and essentially found a very high risk of CSCC in these patients. And if you just look at the current data on transplants, I mean, we perform over 40,000 solid organ transplants in the United States last year, and about 2/3 of those were renal transplant patients. So this number will likely continue to increase. And part of this is directly related to the interplay with the immunosuppression that these patients get post-allograft acceptance to prevent rejection, the use potentially of calcineurin inhibitors, and sometimes we would suggest that they actually preferentially get mTOR inhibitors to try and reduce the incidence of squamous cell in these patients. And what's fascinating is in a non-immunosuppressed population, the incidence of basal cell traditionally used to be 3 to 4 times as high as squamous cell. And in some of the Medicare recipient populations, it may be around 1:1. But in the transplant population, that is entirely switched, and it's about 4:1 in favor of CSCC.
Really interesting. Anna, any comments on this? I know you have a lot of patients who get solid organ transplants where you are. At the end of the slide set, we have a bunch of ongoing studies. I'm not sure we're going to talk about it, but we put it there for you to check out. And there are a number of them trying to address the use of immunotherapy in these types of patients. Any thoughts about that? And do you end up treating these patients and actually having them lose their grafts when they develop disease that's going beyond surgery and radiation therapy?
I think a lot of times it forces us to become very creative in how we use some of our agents. For the most part, I try to stay away from PD-1 agents, especially because patients are not particularly happy with the thought about losing their solid organ graft. But if they have metastatic disease and they've got a kidney transplant, well then, when you speak with someone, the idea of dying of their metastatic disease versus going back on dialysis is really pretty much a no-brainer, I think, for most people, because they're very eager to continue to live without cancer. And if they have to lose their kidney, they will. But for those folks who maybe have locally advanced, or many of our patients are just really covered with thousands of squamous cells that, the dermatologist says, I just can't keep up with them. I've been able to get creative using capecitabine, oral. You've got good control, not necessarily a big immunosuppressive agent. I've also been able to use cetuximab as well in these patients to try to get control. If they've got some limited squames, but they're more of a nuisance, something like a vitamin A, a retinoid, sometimes you can use that topically, will also help control these things.
So I want to get your take. One of the things that Nikhil went through in his talk was neoadjuvant therapy. There's going to be a big presentation at ESMO on neoadjuvant, some cemiplimab, that we're really looking forward to see. But as we just to maybe kind of go through some of the slides that he goes through in his talk in terms of what we know about IOs, which is a typical first-line therapy when systemic treatment's used. Cemiplimab, and the waterfall plots and the spider plots here are really like nothing you see almost in oncology, maybe outside of MSI high. Pembro, you see similar findings. I don't know that you can differentiate it. I should actually warn the audience. I think you just saw that we have a lot of very graphic clinical images in case there are other people on the watching here today, just to let you know. But just amazing stories, and particularly responses that are seen to IOs in these patients. But Nikhil, I want you to talk a little bit about neoadjuvant therapy, where it is right now and where you see it heading in this disease.
Sure. So neoadjuvant therapy, again, everyone is very familiar with that concept, is the administration of systemic therapy for a finite or defined period of time prior to planned surgical intervention, or in obviously the non-surgical case, some form of definitive consolidative radiotherapy. But, this was a disease where we see locally advanced patients. We see tumors that are in aesthetically very sensitive areas, particularly of the head and neck and the scalp. And surgery could become very morbid for those patients. So if we can shrink these tumors down with drugs that can work very well, such as immunotherapeutic agents, that was sort of the impetus for this multi-center phase 2 trial that was actually born out of a pilot study conducted at MD Anderson on 20 patients, where they found very impressive results with a pathologic complete response rate that exceeded 50%. So here, in this trial, 79 patients were accrued, and patients received up to 4 cycles of cemiplimab in the preoperative setting, and then went on to undergo their surgery. These were considered resectable from the start. And one of the collections as part of the data collection here is even trying to see whether the surgeon, prior to neoadjuvant therapy and actually what was performed, did they change their surgical approach or not? But the primary endpoint was pathologic complete response. So this was reported at ESMO last year and then published in the New England Journal. And the PCR rate was about 51%. And then you add the major path response rate to that, so we get about 63% total. And so we anticipate seeing, data from this trial coming out at future meetings, and certainly very, very exciting. I had several patients on this study, and the advantage of neoadjuvant therapy is several-fold, as we've also seen in melanoma with SWOG 1801, where you have an intact tumor. So theoretically, there are intact neoantigens that are available for an enhanced immune response. You can identify progression fairly quickly and may even spare patients a major operation if patients progress very rapidly. And potentially, the biggest advantage that I see is that those patients who have an excellent response on a pathological standpoint, you may be able to risk stratify the need or not for postoperative therapy.
And I'm curious about your clinical experience and when you use neoadjuvant IO, what you see, and also this phenomena that Nikhil commented on, where it looks like the tumor is still there, but you go to surgery and there's nothing that's viable. So you've had a pathologic response, but you don't see it on the imaging. How often you see that?
Yeah, particularly in squamous cell, I think we see that an awful lot. I have a gentleman who had a very large head and neck tumor that invaded his parotid with right-sided neck nodes. And the surgeon said, yes, I can take it out. And I said, well, let's give him some neoadjuvant therapy first. And we gave him 3 cycles of, I believe I gave him pembrolizumab, and there was absolutely no clinical change in what his disease looked like, as well as on imaging. Everything was exactly the same. And, the surgeon said to me, well, looks like it didn't work. And I said, well, don't say it didn't work until we see the pathology report. And sure enough, the pathology report was he was a complete clinical response. Absolutely nothing on pathology. Everything was necrotic. There was no viable tumor. And it was, I think, an eye-opener for our pathologists to actually think that we can get a complete pathologic response and yet not see any real clinical improvement in the disease.
So, Nikhil, maybe you can comment on what this paper coming up at ESMO is going to look at, and some of the things that you'd like to see solved over the next few years in terms of the whole issue of neoadjuvant treatment in this disease.
Well, I think, I've summarized that in this slide. So we will likely see, longer follow-up data. We will likely see, how do patients do, the ones who achieve a path CR versus those who don't. The other data that I think is going to be very important is who really requires postoperative therapy based on what they saw in the beginning. And then I think this serves as a springboard for us to design newer trials, because if we can prove that pathologic complete response in cutaneous squamous cell is a surrogate for durable disease control, then I think the next frontier is how do you actually increase those response rates? So what would be the appropriate marriage partner for an anti-PD-1 agent that we could add and try to go north of 50% PAT-CR rates? Because I think we've already sort of got our work cut out for us as the next clinical trials to move forward.
So let's take a look at some of the responses we got to the survey, because I really wanted to get into since we don't see these patients that often, the nitty gritty of like what's involved in taking care of them. I don't know if we can get through all these things, but this is always interesting when you have two agents that seem similar but haven't been compared. Looks like, Anna, more people are choosing cemiplimab. A couple of people say pembro. From your point of view, Anna, from looking at the risks and benefits, can you separate them?
In my experience, no. I think they essentially come out equivalent. I think one of the other potential advantages to pembrolizumab is quality of life in patients who are working, because you have the option to give them an every 6-week dose. And so they spend less time in the oncologist's office and more time, either working or with their families. But otherwise, drip for drip, I think they're equivalent.
And that is often the case in oncology. We hear that a lot. But another issue, we were talking before about TMB levels, but we asked the faculty, do you even look? Anna said she doesn't even look at PD-1 or order it. But it looks like the faculty, to some extent, in some situations, think that it might be useful in predicting a response. Dr. Weber, for example. And then another question, again, this comes up in oncology a lot, but I think it actually occurs a lot more in your situation, is what do you do with somebody who's having a great response? They're tolerating therapy. How long do you go? A lot of the answers we hear in other tumors, including melanoma, are either 1 or 2 years. Nikhil, you say you can consider after 9 to 12 months. What's your thinking?
So if they've achieved a CR, so one of the things, as Anna mentioned earlier, many of these patients have a fairly rapid response. The kinetics of response tends to be early. So we see a good partial response, almost invariably within the first 3 months. But if you go back and look at the Empower data, particularly for the 2 metastatic cohorts 1 and cohorts 3, and you look at the 1-year follow-up and then 3-year and then more recently the longer-term follow-up as well, patients, the depth of response progressively increased over time. So some of these patients, I would call them late bloomers. Their tumors may develop a CR maybe 9 to 12 months into therapy. So on an average, I would continue treatment in these great responders for around, I think realistically, it becomes somewhere between 9 to 12 months. It's rare that I go beyond 12 months of treatment, particularly if they've already attained a CR by month 6 or month 8.
So, of course, immunotherapy is a very important issue here, but also with basal cell, and certainly the issue of autoimmune complications is important with both. Anna, we asked this, adjuvant lung, for example, also, how often do you see autoimmune complications when you're using an IO in these patients, and what types of autoimmune issues do you most commonly see? And I actually think these numbers are pretty similar to what you might get if you ask for other tumor types. But again, it's a different patient population. We'll talk about that as well. But Anna, can you comment a little bit about what you typically see in this situation and what some of your greater concerns are?
These agents are incredibly well tolerated. Most common, as you can see, based on everyone who answered this questionnaire, rash and itching were really on the top of the list, followed by hypothyroidism. It's the endocrinopathies that clearly are the biggest concern, I think, for most of us, because the endocrinopathies, when they do occur, majority of the time become permanent. And so patients need to understand that what they're doing is committing themselves to taking a different medication to replace the hormone that the immune system has now obliviated. So, that's always a concern. I have to be honest with you that last week I just had a patient who got one dose of adjuvant therapy, IO therapy, and developed type 1 insulin requiring diabetes. One dose, adjuvant. Here's a completely well patient, however, at a very, very high risk of recurrence. So we weighed out the risks to benefits and we decided to move forward with adjuvant therapy. And here she now is a diabetic that needs to learn how to give herself insulin for the rest of her life. So they're not inconsequential. Fortunately, they're very few and far between when they do occur, but they are life-changing events.
I was just reviewing a program we're about to put out on pancreatic cancer, like FOLFIRINOX and Nalirifox, and I was thinking if we were to ask the next question, which is, who's the oldest patient you've treated and how did they do? I don't think you'd see these answers. You're the winner, Anna, 101 years. Anything else you want to say, Nikhil, about your experience with autoimmune toxicity? One of the things that comes out in almost all these programs is whether there's a correlation with autoimmune toxicity and treatment benefit. I hear more and more people sort of buying into that concept. Any thoughts in general about the autoimmune problems that you see with both of these diseases, Nikhil, and whether, like, if you see something, do you go, oh, well, maybe your chance of responding is better?
We've not really identified that in either of these skin cancers. The toxicity, again, to anti-PD-1 monotherapy is very tolerable, with the exceptions, again, what Dr. Pavlick already mentioned. I think one of the takeaways from particularly this slide here is that these drugs can be given very safely to our geriatric population as well. I mean, this is not a population that I would routinely give a platinum agent to. Or chemotherapy. And so if the same thing had occurred 10 years ago, we would have been talking about palliative care to these patients. And so now I think, and there's emerging data, already published data, that clearly tells us that the geriatric population tolerates these drugs exceedingly well with no compromise of efficacy.
Of course, one population that does have a problem, as we've been talking about, is people who are on immune suppressives for solid organs or hematologic transplants. I was just curious whether anybody had ever treated patients like that. And so we asked about allo. And actually, Anna, you said you treated this 57-year-old patient. What happened there?
He was an allo transplant. And he had a minimal response, and he passed away from metastatic squamous cell.
And I see Dr. Lipson also treated a patient. Of course, the other thing we were talking about is solid organ transplant. Nikhil, what happened with your 75-year-old patient with the kidney transplant? He rejected.
This was an unfortunate case. I mean, I started him on cetuximab as frontline treatment for advanced CSCC, and the first dose of cetuximab, he had essentially an anaphylactic reaction. So obviously we could not re-challenge him with that. So we had a pros and cons discussion and moved forward with anti-PD-1 therapy. And after 3 doses, he got admitted to his local hospital with a creatinine of, I think, 6+. And this is somebody who had a kidney for over 20 years as an allograft without a problem.
Wow.
So that was very disappointing. And then, so he's on dialysis, but had a PR. So we haven't had to retreat him. And the hope is that this will remain durable. And then the other patient had a liver transplant and did well from a liver transplant standpoint, but had progressive disease. On the allogeneic stem cell transplant, I've treated a patient, but not CSCC. That was a young individual with Merkel cell carcinoma with status post-allo, and unfortunately did not respond.
So, Anna, I was curious, too, about second-line therapy. You know, I was saying when everybody gives the same answer, we call it a consensus. I'm going to say that maybe there's not exactly a consensus about exact second-line therapy, although you do hear a lot about cetuximab, and also the issue of intralesional therapy. I'm curious about your experience with that. How do you approach second-line therapy, Anna? And can you talk a little bit about your experience with intralesional therapy with these with squamous cell and what situations you do that?
Sure. Cetuximab is usually my second line after PD-L1 failure. Sometimes I use cetuximab with chemotherapy, such as capecitabine, just to get more of a response, a faster response if someone's got very large fungating lesions. I think it really is a matter of looking at the patient and what they tolerate. But looking at intralesional therapy, at least for these patients with large tumors, I have several clinical trials open with intralesional therapy. And so those are the patients that I routinely will put on a clinical trial, inject the lesions, and many times those lesions do respond. But the intralesional injection is also with systemic anti-PD-1 therapy.
Yeah, I was going to ask about that, Nikhil, and I think there's a trial that's sort of cooking or maturing right now, combining PD-1 with an intralesional agent. What are the types of agents that are there? I think we had a little typo on your thing. You said IL and they thought interleukin, but it was actually interlesional.
Interlesional, right.
Right. But in any event, any comments about your experience with this, where you see it heading, and particularly this issue of combining interlesional and immunotherapy, which kind of sounds interesting.
Absolutely. So there is a trial that has completed accrual. This is the SURPASS study in cutaneous squamous cell. This is intralesional RP1, and the trial is examining standard of care cemiplimab with or without intralesional RP1 for these patients, with the endpoint being complete response rate, and this is a registrational study. So this has completed accrual. We anticipate results sometime hopefully later this year. And, that is certainly exciting. There are other agents that are being investigated in this space as well, including TLR agonists. So that should hopefully be coming down the pipeline as well. Certainly, TVEC has been used in an off-label manner previously. I think that's primarily the domain of case reports or smaller case series. Certainly not unreasonable to consider an agent like TVEC if we've exhausted our other standard treatment options, but it's highly unlikely that they will respond by themselves. See?
So I'm going to move on to basal cell, but I just want to flip through, and you can check these out later if you want. And also we're going to be emailing these out as well. Some of the responses related to neoadjuvant adjuvant therapy. We do this thing where we say, tell us about the last patient. And then when you start looking at 10 people, there sort of kind of becomes a little bit of a pattern. So we said, tell us about the last patient you gave neoadjuvant therapy to. And you can see there's a bunch of people who had great responses or path responses, older people, 84, et cetera. And in terms of which agent, kind of a flip, as you might anticipate based on what we've been talking about between cemiplimab and pembrolizumab. I was also curious whether people would, there's trials looking at the use of adjuvant therapy. I was curious whether people would use that right now outside a protocol setting. I'm just going to flip through and say in general, I think people are not going for adjuvant therapy except in unusual situations. What about, Anna, post-op radiation therapy? What are the situations where you utilize that? You say close margins, perineural invasion, or multifocal disease.
Yeah, I think most of us would certainly give post-op radiation to patients, especially with perineural invasion. We know these patients can have long-term neurologic deficits if you leave residual tumor behind that just essentially coats the nerves. I think looking at everyone's list, looking at multifocal disease, extracapsular extension, multiple nodes. I think the rule used to be, at least in melanoma, you'd radiate if you had 4 or more positive nodes. I don't even think we radiate in melanoma anymore. But yeah, there's lots of indications, and I think to improve local control, it really is significant and something that patients sometimes don't like to do because it requires time, energy, and effort. But for every patient that has a recurrence in that nerve distribution, they always come back and say, I should have listened, I should have done it. Now look what happened.
So I'm just going to flip through some of the slides that were shown by Nikhil. Hopefully you'll watch the talk and he'll go through all these cases. These are very dramatic photos, but really, I think what probably the audience has seen as well in terms of really interesting visible responses. While I'm clicking through these, Nikhil, interesting question in the chat room from Hassan. Any explanation why cemiplimab seems to be so active in squamous cell? He points out it's very, very active in squamous of the lung, cervical cancer, now skin. Anything different about cemiplimab, or is this just where it's been studied?
I think it's primarily where it's been studied, and also the patient population. For example, if you look at the eligibility and the types of patients that were enrolled in EMPOWER, the registrational trial in cutaneous squamous cell, very few patients in that trial had received prior systemic therapy, i.e. chemotherapy, or other treatments that we would use, as opposed to, for example, the keynote study that led to the approval of pembrolizumab had far more heavily pretreated patients. But when you look at pembro alone in patients that are chemotherapy naive, the smaller subset, the response rates are very similar to what we see with cemiplimab. I will certainly admit to the question that what I cannot clearly explain is why is the progression-free survival with cemiplimab noticeably higher on the EMPOWER study relative to, for example, the keynote studies or the CARSKIN trial. I really don't have a very clear explanation for that. But that's certainly something that I think we will see further. Like the SURPASS study has cemiplimab as one of its standard of care arms. So as that study matures, we will see if that replicates what we had seen in EMPOWER.
So one final question before we go on to basal cell, just coming back to you, Anna. Looking at these photos, which is really amazing how these people responded, but also amazing how far advanced they are. I'm curious about sort of the socioeconomic background of these patients. You look at things like that, and I think a lot of people think, homeless people, people with psychiatric addiction problems. But I also think about some of the cases of breast cancer we talk about, of women who, they have jobs, they're taking care of a family, and they just have this pathologic denial and present with lesions that can look, very, very obvious. I know you can't characterize it in general. I love to make rounds with you. I can imagine it must be a very interesting clinic you have, Anna. But can you talk a little bit about the types of patients you take care of and sort of dealing with the issue of these really disfiguring lesions?
Yeah, I think they really do fall all over the map. I don't think you can just say that these are lesions that occur in an underserved population. I think we see a very high tendency of these lesions occurring in elderly that are either in nursing homes or essentially neglected lesions. But likewise, as you had just said with the breast cancer, I just had a patient come into the office who is an executive and came in and said, I'm here because I feel like everybody can smell it now.
Wow.
So you can only imagine what was underneath the bandage that was on her back. And so there was this very large fungating lesion that was foul smelling and was so deep that it was essentially attached to the rib and attached to the muscle. And so this person actually wound up getting neoadjuvant therapy, but clearly not someone that I would ever in my head imagine coming in with such a necrotic large lesion. And her answer was, well, I knew I had something there. COVID hit. I wasn't going to go to the hospital. And then when we finally went back to work, I've just been so busy. So I just kept bandaging it and saying, I'll get to it.
Yeah, the impact of COVID also certainly is something to think about. So we're going to move on to basal cell, but just interesting in the chat room, I see a comment that says, quote, "My understanding is that immunotherapy's second-line treatment is cisplatin. Please correct me." You stand corrected, I guess, because I hate to be giving cisplatin to somebody when you could get an IO and see those kind of responses. But let's talk about basal cell, where actually the first-line therapy is hedgehog inhibition, and we don't see we see great responses to IO, but not quite the same. And I'll start out in the beginning of her talk. Anna went through the fascinating biology of this disease, and these again are typical first-line therapy, although we'll talk about exceptions. Nikhil, what's your vision? And go to Anna's talk to get into the details, but Nikhil, what's your vision about the biology of what's going on here and why hedgehog signaling pathway inhibitors are so effective?
Well, I think it's primarily, you can actually see this on the slide that you have up there, is the vast majority of sporadic basal cell carcinomas have mutations in patch 1. And as a result of patch 1 mutations, you have constitutive activation of the hedgehog pathway that allows the eventual development of basal cell carcinoma. Now, this is a slow process, so these tumors take months, if not years, to eventually develop to a point of becoming locally advanced. And, conversely, when you treat them with hedgehog inhibitors, right now there are 2 that are available, vismodegib and sonidegib, it takes a while before you actually see these responses. So you really have to be patient by targeting that pathway and essentially shutting that down.
So these are very effective agents, but also they're not the easiest drugs to give. Anna, maybe you can talk a little bit of this really unusual and very striking side effect profile of these agents.
Sure, of course. Much unlike immunotherapy and unlike chemotherapy, these agents have a very distinct toxicity profile with muscle spasms, alopecia, taste changes, and anorexia, followed by fatigue. They're very notable. And when you think about the patient population that you're treating, many times these are older patients who already have taste changes or thinning hair or muscle spasms, and you give them these agents, although they're very effective, you just accelerate their fragility because they lose a lot of weight, they stop eating. I've had patients say, I don't even like to go out with my family because everything tastes the same. And so they lose their drive to want to socialize with friends and family because they just, A, don't like to eat because it's not satisfying, but B, they just don't like, there's just no drive to do that. And I think the other side effect that we really do need to touch on is the muscle spasms, because for the longest time when we did these trials, that was clearly one of the toxicities that we all kept documenting was muscle spasms. And we would have patients taking magnesium and, telling them to exercise, using muscle relaxers, doing stretching. I think the classic that I always recall is a couple of docs from the South were saying they were telling their patients to drink pickle juice because it was high in sodium, high in magnesium. And just the thought of that made me just think that I'd be stopping this drug because I'm not drinking pickle juice. And we found amazingly low dose amlodipine at 10 milligrams at bedtime really does improve these muscle spasms and allows people to sleep and that not be usually a rate limiting factor.
Nikhil, any comments about the adverse profile of these agents? Any secret remedies? Maybe something more appealing than pickle juice, but anything you found?
I've actually suggested to patients, particularly for the cramps, to drink tonic water. Particularly, add a little bit of lime to it, and because of the quinine component, I don't know whether that's placebo effect or truly benefits them. I must admit, I'm not as optimistic as Anna is with regards to the use of amlodipine. I've tried it. And I really have not seen that much of a benefit for these patients. But maybe, we've been using on the lower side, the 2.5 to 5 milligram dosing. And maybe it is the 10 milligram dosing that we typically use in hypertension that may be beneficial to these patients. So certainly worth a try, particularly if you want to continue the drug and it is efficacious.
So speaking of home remedies, Anna, Dr. Kumar in the chat room is in the Florida Cancer Specialist, and hopefully I'll see him on Saturday. He's always presenting cases in our chat rooms. Here's his comment, Anna. Let me know what you think. When there's a large necrotic, fungating, foul-smelling lesion, I use metronidazole crushed in powder and applied to the wound.
Yes.
He finds it very effective. Do you ever do that? I never heard of that, but have you ever done that?
Yes.
Really?
Yes.
We do it all the time.
It has to be compounded.
Do it all the time.
Yeah. And you make it into essentially a metronidazole spray or a lotion. And very effective.
Wow.
Yeah. And I've
Nikhil,
done
he
that.
Also...
that was a trick I learned during my hospice rotation years and years ago.
Wow.
This was for wound management at home. And I've used it all the time since then.
Wow. Dr. Kumar follows up by saying he drinks tonic water lime twist daily for muscle cramps and advises it for his patients as well. Anna, you went through, relevant to both of these tumors, and we already talked about immune-related adverse effects. But the thing I wanted to ask you about is the idea of re-challenge. I know most of the immune-related problems are usually not life-threatening, but they can be. So what about, for example, grade 3? If a patient completely recovers from it, they've had a great response, but they still have disease. How do you think through re-challenge, Anna?
I certainly would never say never. I think depending upon the patient's age, performance status, response to the initial therapy, if the patient is willing to accept the risk of having recurrent toxicity or other toxicities, many times I am agreeable to restart. I think now that I think most of the toxicities where you get grade 3 is really with combination immunotherapy. So I think now that we've got differing doses where we can use, quote, a flip dose, sometimes I go back and say, let's use this dose as opposed to full dose and see if we can get away with it. But with single agents, it's incredibly rare that I see, grade 3 or grade 4.
So again, first line systemic therapy for basal cell consensus. Just kidding. Interesting here. So first thing, Nikhil, in terms of if you're going to go with a hedgehog inhibitor, is any preference one versus the other? Anna, I think more because she started using it first, uses Vizmo, but and so does Dr. Reddy. A couple other people say either one, coin flip. Really interesting that a couple of people say PD-1 first, which I can imagine there's situations for sure where you might want to do that. Any thoughts about the responses here, Nikhil?
I actually find that interesting because, if you look at the formal labeling for cemiplimab, it doesn't exclude the possibility of using it in the frontline setting because of the way the label reads. That being said, I think we need more data in the frontline setting. While you can use it, these are drugs that are not as efficacious as we see, for example, in cutaneous squamous cell carcinoma. Dr. Lipson had a very interesting poster that was presented. There's a poster discussion at ASCO where they looked at nivolumab for basal cell carcinoma, again, off-label use at this point, but showed a good response rate in therapy-naive patients in the frontline setting. And then if they progressed, they went on to receiving either Nivo plus Rela or Nivo plus ipilimumab. So again, a small cohort of patients, but certainly gathering more data. And if we see that this allows us to treat patients for a finite period of time, but more importantly, a durable response, So you give it for 3 to 6 months, and then you don't have to treat these patients again. I would absolutely consider it earlier in the course of their disease. But otherwise, outside of that, I would still prefer using a hedgehog inhibitor.
Anna, what's your thought on this? I mean, it seems like the quality of life, at least certainly that's not the only issue, but quality of life is going to be in toxicity very, very different for these two approaches. Are there situations where you look at somebody and just go, no, I don't think they're going to do well at all, and we'll try an IO?
Yeah, I think there certainly are. I can honestly tell you about a patient who came in who is 95 years old, has squamous cell, basal cell, and Merkel cell. Well, here's your home run. You've got the triple. You give them a PD-1 inhibitor and you manage all of them. And he has had a remarkable response in all of the lesions that he has.
Wow. That's cool.
Yeah, which I never thought I'd find a patient with all of
Chicken
the same
soup.
Lesions to treat. Excuse me?
Chicken soup. Chicken soup. Works on everything. Just kidding.
It does. Well, take out the fluoride in water and put PD-1 in instead. I think we'd be better off.
So also, we asked the issue of what do you do? How long do you keep these drugs, the hedgehog inhibitors, going? And I guess there's a variations. Dr. Hamid says indefinitely. Other people, Nikhil says 9 to 12 months. And I'm sure a lot of it has to do with how they tolerate it. And again, you don't see these kinds of answers with many other types of treatments in oncology, but I think everybody just talks about the same exact things that Anna just talked about, and really a real challenge, I think. These are some of the things that people do. This is interesting. Dr. Lipson says, avoid metal silverware, addition of hot salt or hot sauce. Interesting. Nikhil, does that make sense? Metal silverware. Any idea why that would trigger, I guess, dysgeusia?
I'm not sure about that. I'll have to talk to Evan and get his insight into that. Evan's a really smart guy. So if he says that, I would
creative.
trust him. Yes.
and very creative. What about the issue of hedgehog after hedgehog? Anna, any reason to think you could get benefit if they've had previous treatment? What about if it's, they start with hedgehog, then they go to IO? Can you come back to hedgehog?
Can't see why you can't. But if they didn't tolerate the hedgehog and you switched them back to IO, I can't imagine why they would tolerate the hedgehog a second time around. If they tolerated the hedgehog and they just didn't get the response that you wanted them to have, it's not often that I go back to hedgehogs because I usually leave them because of the toxicity.
So in terms of people who progress on hedgehog, obviously IO is next for almost everybody. That's cemiplimab. We asked people what the duration was of the longest duration of response they had seen. You can see there's variations. And also variations in how long they continue PD-1, a la what we were just talking about. Anna again wins the award for oldest patient who got treated with 99. But again, you see how well these people, even in advanced age, both tolerate and respond to therapy. Anna, can you talk a little bit about Gorlin syndrome? I'm not sure how many patients there are out there like that and whether people in community practice see these patients. But obviously you all do. And can you talk a little bit about what this topical gel is?
Sure. So Gorlin syndrome is essentially basal cell cancer syndrome. Patients can present, their lesions are usually pigmented. They occur usually in a younger population. Patients also have frontal bossing. They usually have a very particular look about them. It's not often that I see them. However, when they have just so many basal cells that the patients say to the dermatologist, you just can't keep cutting me. That's when I usually get them referred to me. my frontline go-to is a hedgehog inhibitor, but I use it very sparingly. Once these patients have resolution of their lesions or have one or two that the dermatologist can cut off, I stop and then monitor them, because these are patients that are going to be cycling through basal cells for the entire course of their lifetime. I have given some anti-PD-1 therapy. At least in my experience, I have not had a very good fortune when I've treated them with anti-PD-1 agents. I appear to get much better bang for my buck when I cycle the hedgehog inhibitors. And what is the gel is a hedgehog inhibitor gel. And I have absolutely no experience with that. I think that's something that the dermatologist would have much more experience with.
So, Nikhil, oncologists always combine things, and Hassan in the chat room wants to know, what about combining hedgehog and IO?
That's actually been done. There was a small study that came out of California. I can't recall whether it was the Stanford group or the UCSF group, where they combined pembrolizumab plus hedgehog inhibition, and saw a small study. I think it was 14 patients, but saw a fair amount of toxicity and no significant increase or additive or synergistic efficacy. So at this point in time, I would not do that outside of a clinical trial. I think sequential therapy is more appropriate for these patients.
So let's finish out with a few cases. And again, in Anna's talk, she goes into more detail, but just again, even to take a look at the pictures. 88-year-old man, what happened with him, Anna?
Well, he flew up from Puerto Rico to live with his family, presented with this large ulcer on his nose, was taken to the dermatologist. That's a picture of the lesion. Biopsy was consistent with an invasive basal cell carcinoma. He was offered surgery or radiation therapy. He said no to both, at which point he was then referred to me. I started him on a hedgehog inhibitor. I gave him vismodegib, and he actually had a very dramatic response. But after 6 months on therapy, his toxicities became intolerable, and so he refused to take the medicines anymore. So I sent him back to the dermatologist and had blind biopsies done in the area just to confirm if there was any residual BCC, and there was not. And so I just continued to have him followed closely by the dermatologist, and we did not go back and give him treatment.
How did he do dysgeusia-wise?
Terrible. He hated me. Although his nose got better, his joy in life was smoking his cigarette, having a cup of coffee, and eating with his friends. And he still continued to smoke. He still continued to drink the coffee, but he didn't enjoy his meals with his friends anymore. So he was very, very happy to stop therapy.
Well, you had a really great response, it seems. Nikhil, any comments about this case? And do you ever use consolidation radiation in this situation? What would you have done if any of the biopsies were positive, Nikhil?
I agree. I think we have done that. We've done that more for cutaneous squamous cell, consolidated radiotherapy, but BCC responds very well to radiation as well. So we would have done exactly the same thing that Dr. Pavlick did. And these patients who develop a CR, many of them maintain their CR.
So another 80-year-old, lots of 80-year-olds in your clinics there for sure. What happened with him, Anna?
Well, he was a gentleman who was treated with a local basal cell on his scalp, resected through Mohs, did fine, and about 8 years later had a recurrence within the surgical bed. He also refused to have any further surgery or radiation, and so he was sent to me. Started him on a hedgehog inhibitor, and he just lost his desire to eat, and he lost a dramatic amount of weight in a very short period of time. So I was given no choice. Although he was responding, I stopped his therapy due to toxicity. When he recovered some of his weight and felt better, he was started on cemiplimab, which he tolerated really well. He was on therapy for a full 2 years because he had a very slow resolution. But he's had a durable response. Not the usual that you usually see with basal cell, but he was also on it for a very long time and did not have
Nikhil,
toxicity.
Any comments about this case, Nikhil?
No, I think it actually follows the paradigm that slow responses occur in basal cell relative to the much faster kinetics that we see in squamous cells. So again, stable disease in BCC to an immune checkpoint inhibitor is not necessarily a bad thing. I would just wait, continue the course, and sometimes you see delayed responses in BCC as well. We have a patient very, very similar who came with draining wound fistula from the axilla, and that had progressed on frontline hedgehog inhibition. And he is just about completing 2 years of cemiplimab and has had an essential CR to his treatment.
Really interesting. So Anna and Nikhil, thank you so much for joining us today. Audience, thank you for attending. Get ready for Saturday. I'm ready. We'll be up in Orlando. If you're not there, just tune us in. We should have a great time there with a Florida cancer specialist, and then the following week in Las Vegas. I'm actually going to check out the Sphere when I'm in Las Vegas. I'll report to you when we begin that symposium what it's like the night before. Be safe, stay well, and have a great night. Thanks so much, Anna.
Thank you.
Thanks, Nikhil.
Thank you.
Have a good one.
Bye-bye.
Take care.